afternoon of the 3-day Annual Congress of Advances 2025. The energy and enthusiasm so far have been really incredible, and we are expecting more enthusiasm and inspiring speeches and discussions in the evening sessions as well. We kickstart the evening session with the keynote address. May I please invite the chairpersons onto the stage. Dr. P.K. Shyamala Devi, Dr. B. Sharda Devi, and Dr. Sujamol Jacob. And we have the keynote address rendered by Dr. Amarnath Bide today on the topic Fetal Size and Stillbirth. May I please invite him onto the stage for the keynote speech. It's my privilege to welcome him once again for another talk the same day. Dr. Amarnath Bide will be here soon to say a few words about Doctor. He is the consultant in fetal medicine and obstetrics at the St. George Hospital in London, the UK. And he is a lead for the Day Assessment Unit and honorary reader at St. George's University of London. He's a co-director of the MFM subspecialty program. He's a deputy chief editor for Acta Obstetricia, Gynecologica Scandinavica, and member of the editorial board for 2 other journals. Doctor's research interests are in placental physiology and pathology, hypoxemia, and fetal cardiac function. His clinical interests are in invasive prenatal diagnosis and therapy, multiple pregnancy, and problems with fetal growth. He has published over 200 peer-reviewed articles and many book chapters, and he has co-authored 5 books. We are privileged to have him with us for Advances 2025.
Thank you once again, Dr. Jayakrishnan, to ask me to speak at this Congress, this meeting, and it's very exciting for me to speak to you here. What I'm going to talk to you about today is to convince you that focusing on the size of the baby is not the only thing that we should be worried about or concerned about. Why are we so worried about small babies? Because they are at a higher chance of developing or experiencing a stillbirth, right? So our concern is that if baby is small, the baby may have experienced stillbirth, and that's something that we want to avoid. But I'll explain to you why it is not such a good idea. Now, I'm sure many of you have seen this study. The Pregnancy Outcome Prediction Study, POP study, has been published some years now, and basically what it did was it estimated the ability of routine ultrasound scans for the diagnosis of small for gestational age babies as compared to no routine scans, so clinically indicated scans. And what we learned from this study is that selective scanning identified approximately 20% of small babies. Of all small babies, only 20%, 1 in 5 was detected. And for universal screening, it was increased to about 57%. So what it means is that we are missing, in spite of scanning everybody, we are missing about 40% of small babies. Now you might ask me, what do you mean by small babies? So we are talking of babies who are smaller than the 10th centile, so babies estimated weight smaller than the 10th centile. They are missed. 40% are missed by, even if routine scans are done, and these scans were done at 36 weeks of gestation. Now, how about if we say we are looking for very small babies? So if the baby's weight is less than the 3rd centile, does that become any better? A little bit. So routine scanning increases it from 57 to 77%. What is important to remember is that still we are missing 1 out of every 5 babies. In spite of scanning everybody, we are missing them. We are not detecting them. So we are not particularly good at detection of small babies before babies are born. So that's our first hurdle that we want to cross. Now, this is also a very good study looking at if we are doing scans for smallness, detection of smallness, when should we do it? And this is a randomized controlled trial published again for some time back, screening for fetal growth restriction at 36 versus 32 weeks. And you see here that there is the ROC curve And here we see scans at 32 weeks. The sensitivity is less than 50% at 5% false positive rate, which increases to about 65%. So very similar to the POP study when the scans are done at 36 weeks. So what we learned from this study is that if at all we are doing routine scanning or screening ultrasound for detection of smallness, we should do it as late as is possible. 36 weeks, we are detecting twice as many small babies as compared to scanning at 32. So if we shouldn't do it at 32, we should do it at 36. But we are going to miss still 1 in 3 babies who are small. And that is the fact of life. Now, when we are estimating the baby size, it's not just saying we will estimate baby size, because there are several kind of formulae available which will calculate or estimate the baby size depending on the biometry. Because we can't weigh the baby while the baby is still inside. We are going to measure, put the measurements in a formula, and then come up with an estimated weight. And this is a study from the King's group, the Fetal Medicine Foundation group, and they compared their own study, and they did scans on several thousand women. To their surprise, their performance of their own formula was no better than the formula that was published in 1985, the first ever Hadlock formula, and that was based on that, and they did no better. So theirs was comparable to the Hadlock size using head circumference, abdominal circumference, and femur length. So all the other formulas, there have been several, and you can see how many formulas there have been, they don't perform as well, and when we are calculating or estimating the size, this is the formula that we should be using. Now, if I ask you a question, most stillbirths at term have an estimated fetal weight below the 10th centile. Would you agree with me? That is what we are worried about, isn't it, when we see small babies? Would you agree or would you not agree? How many would agree? How many would disagree? Quite a lot would disagree. So this is a graph whereby babies' weights are put against the reference range. What we see here is that there are 110,000 pregnancies here. What we see here is that when we are talking of preterm growth restriction, the majority of the babies who are dead are below the reference range. But look when we come to 36 weeks and above, and these are the babies' weights on the reference chart. Majority of babies who are born at term and are stillborn, they are not SGA. So majority of preterm babies are SGA, but 70% of term stillbirths are not small. Now, mind you that when the babies are small, we know that babies lose weight. And the longer the time period, because baby is dead now, doesn't get delivered straight away, so may remain in utero for some time. And the longer it stays in utero, the more weight it loses. So irrespective of it, this is not the previous graph, this one has not been corrected for the interval. Still, 70% are not small. So we would expect more to be small. But no, even if they lose weight, still they are within the reference range, which is quite surprising. So a large majority are actually not small. And this study showed 85% of term stillbirths are not small. Question comes up is, when we are putting the baby's weight on a reference range, what reference range are we using? Because there are several kinds of reference ranges available. But what we do know is that if you are making a diagnosis of smallness, this diagnosis must not change just because the baby is born. So if the baby was small or defined as small before birth, even if the weight does not change, it should not be then not be small just because baby is born. So in simple terms, the EFW and birth weight should match the formula, the reference ranges for babies who are born before birth or preterm, and babies are born post-term, post-birth, they should match each other. And there are very few formulae that do match, and intergrowth is one of them. They do have a reference range for intrauterine growth, and they do have a reference range for postnatal growth, and they do match. So if a baby is, for example, to give you an example, if we estimate the baby's weight to be 3,000 grams, it will sit somewhere on the reference range in the prenatal charts. If the baby is born at the same instant and the birth weight is exactly the same, 3,000, it should sit, or it will sit at the same level in the postnatal reference range. So they exactly have to match. They can't change because because nothing else has changed. Baby's weight hasn't changed. So we should be using those reference ranges for detection or for the definition of smallness. Now, one of the armamentarium that we have got for smallness and reducing stillbirth is to deliver them, right? We say that the baby is small, we should deliver because there is a risk that the baby may have stillbirth. Now, is it always safe to deliver small babies at 37 weeks? What do you think? Is it safer? Is it good for the baby? Now, there is a big study looking at late preterm birth and special educational needs, and see what happens here. So, unsurprisingly, if the baby is born very early, then there is a high chance of babies requiring special educational needs. But see how this is a continuum, and the lowest point is not until you reach to 38, 39 and 40 weeks. What it means that even mild prematurity is not without risks. So there are still these babies, they are different as compared to, for example, here 35, 36, quite different from here. The lowest point is actually 41 weeks, babies which are born at 41 weeks. That's where the risks are the least, and then it starts rising up again, and because of other reasons, because they have got problems when they are still in utero for a longer time. So it's not as easy as saying that if you're worried we should just deliver them, because there are risks of early delivery as well, and we must not forget that. This is again a graph from the POP study, pregnancy outcome prediction study, and it shows that estimated fetal weight is not a good predictor for long-term developmental outcomes. What is related to it is this umbilical artery Doppler, which is unsurprising. We know that it's a good indicator of placental insufficiency, but abdominal growth velocity is the only one related to the weight, which is related to risk of neonatal composite adverse outcome associated with diagnosis of SGA. So just the weight doesn't count. The growth velocity is important, and when that isn't taken into consideration, estimated weight, fetal weight goes out of the window, and I'll show you some evidence about that also. Now, question: do we die of starvation or do we die of hypoxia? We die of hypoxia, isn't it? So, being small is an indicator of starvation. Placenta isn't working properly. Now, SGA is it a symptom or is it a disease? The pathology is the placenta is not working properly, and the symptom is that the baby's growth is slowing, that is food, and death or disability, that is less oxygen supply. But stillbirth and developmental handicap are related to hypoxemia. They are not related to malnutrition. In other words, just being small is not a crime unless there is also hypoxemia associated with it. Now we look at the needs of the baby, the nutritional demands, and the respiratory demands, they don't run in parallel. And there are differences in the way they evolve. Earlier, fetal nutritional requirements are far higher, and if they're not satisfied, the baby will become small. Later on, the respiratory requirements become increasingly higher, and look at the slope at which it is going up, exponential increase in respiratory requirements. So if something happens closer here and the placenta doesn't work as well, then because the rate of growth is so quick, there isn't enough time for the baby to be small before it runs out of its respiratory requirement. And that is why if here something happens here, this is what gets affected and baby becomes small. Something happens there, the growth requirements, the nutritional requirements are relatively modest, and that's why the baby may not be small. And to show you here, this is the baby's size at this point, and then placenta stops working, baby becomes small here, we see it, we make it a diagnosis. If something happens here, yes, baby's growth rate is also going to be below, but the reference range becomes wider as the gestation age becomes advanced, gestation advances, and by the time it gets to there, baby is still not small, but it has run out of its respiratory requirements, and baby is in trouble there, and that's why stillbirth can happen. So, question comes up is how should we monitor fetal growth restricted growth restricted babies? And there are several ways of doing that. Cardiotocography is something which is quite often used, and there is RCT evidence showing that computerized CTG is far, far superior as compared to visual interpretation as far as antenatal CTG goes. And that's something that we do use. If we are using antenatal CTG, it is a computerized CTG that we use. Now this is some Doppler data. Doppler is often used for making a diagnosis of growth restriction. So this is CPR, and I'm sure people have heard about CPR. CPR stands for cerebroplacental ratio, and that's the ratio between umbilical artery Doppler and middle cerebral artery Doppler, and that shows you that if you're looking at perinatal death as the outcome, which is the gold standard for the outcome, then birth weight centile, crude odds ratio is that and highly significant. But if we adjust it by taking into account uterine artery Doppler and CPR, it loses significance. So on its own, smallness doesn't correlate with CPR if we take into account with mortality, if we take into account CPR. So just being small is not enough. And those are the adjusted ORs that I've just shown you. This is a meta-analysis of 128 studies, 47,000 pregnancies, and CPR is significantly associated with perinatal death. There's another one where predictive accuracy of CPR for adverse perinatal outcome. The sensitivity is that 93% for prediction, specificity 76%. So if it is abnormal, it doesn't mean that they will be wrong. But if it's normal, it's a very good test to exclude problems happening in that particular pregnancy. So here is a proposed algorithm as to how to monitor these babies. We do an ultrasound here. If the baby is below 5th centile, and we are talking of term, we are not talking of preterm here. So if we do an ultrasound scan and no, it's not working. Anyway, if the baby's weight is estimated to be below 5th centile, we recommend we deliver, because normal Dopplers doesn't tell us, doesn't reassure us that the placenta is working okay. If the baby's weight is below 50th centile, but not below 5th centile, so in the lower half of the reference range, if the baby has got low CPR, we should still deliver because it's telling us something about placenta not working. If it's normal CPR, then we can reassure because it's a good rule-out test for problems to come. If the baby's weight is in the upper centiles, between 50th and 95th centile, then it's a good sign because the baby has not even begun to get smaller. So we can reassure here. If the baby's weight is below the 95th centile, this is macrosomia we're talking about, probably deliver because there is good evidence that there is a higher chance of developing problems here also, particularly with related to shoulder dystocia. So this is a proposed one. This has not been tested ever, and unless that's been tested, we don't know that's the right thing to do. So in summary, what can we say about placental dysfunction at term? We should stop some things, doing some things. We should stop using symphysis fundal height. Why? Because the sensitivity for symphysis fundal height for measurement of small babies is at best 20%. 1 out of 5. So 4 out of 5 babies we are not going to pick up. So we should not waste our time in doing symphysis fundal height measurement. Second thing we should stop doing is customization. Now again, at one point in time in history, there was a enthusiasm about customizing everything. But now we know that customization doesn't actually work. There is no evidence showing that customization improves the outcome. All it does is that apparently customization puts more babies into kind of reference range, but ultimately it doesn't make a difference to the ultimate outcome. We should continue to do 36-week scan if we do it. So if we are screening the population for smallness, we should do it at 36 and not at 32 because we've got good evidence that we increase or double the predictive power. For estimation of fetal weight formula, we should continue to use Hadlock formula because it works very well, and there's again evidence for that. And we should use those reference ranges where the birth weight centile and the neonatal weight centile match. They don't differ. We should consider delivering babies below 3rd centile at 37 weeks. Deliver less than 10 centile babies from 39 weeks onwards because I showed you the developmental needs. They are fairly low at 39, 40 weeks, but before that not. And then we should consider the role of CPR and umbilical artery Doppler. So at term we know umbilical Doppler alone does not give us that reassurance that this baby is not going to get into trouble. Does it mean that we should do CPR on everybody? And if the CPR is low, we should act on it. So for that, I would want you to look at this particular manuscript, and this is the only one that I know of, which is looked at reproducibility of cerebroplacental ratio, and that's the reference range, and those are the repeatability measures there. So to give you an example, the graph doesn't tell you much. To give an example, mean CPR is reported to be 2 at 27 weeks. That's the 50th centile. Okay? But the 95% limits of agreement show that it could be as low as 0.9 or could be as high as 3.1. That is the 97.5th centile. Okay? So there is a large variability of CPR at any gestational age. So before we start acting on CPR, just because the CPR is abnormal, we must be sure that it is really abnormal. So I would strongly advise you not to act on a single measurement. We should try to make as many measurements as is possible, get a value which is consistent, so it should be consistently what we are getting along the same ballpark figure. And if you're consistently getting a low CPR, then you've got to take it seriously. Because if you are making several measurements and that's not changed, chances are that it is real. And then we've got to take it seriously, we've got to keep that in mind. We've got to take it into consideration. And if the baby is small at term, then we have got to consider, and in addition, the CPR is abnormal, you've got to consider delivery for this particular baby. So I hope that I've explained to you or convinced you that smallness is not everything. Looking for smallness for reducing stillbirth is something similar to looking at maternal age for screening for Down syndrome. At one point in time, we used to do that. We used to say anybody beyond 35, 37, whatever you call it, those are the women at risk for developing having Down syndrome. But we now realize that we will only pick up a small proportion. Similarly, if we concentrate all our efforts on small babies, we will miss majority of stillbirths. So for that, we've got to go beyond smallness. So I'm not denying the fact that babies are small, they are at a higher risk of stillbirth. But if you only concentrate on that, we are not likely to pick up majority of the stillbirth. And for that, I've proposed some algorithm which may be useful for us in the future. So I hope I've convinced you that size alone is not everything. Thank you very much.
Thank you, sir, for the inspiring keynote speech. And your insights have truly set a visionary tone. Dr.